I thought it would be funny to juxtapose oncogeriatric issues after an allogeneic transplant talk. So I'll go through how we can care for our older patients and some of the strategies that we're integrating, and then end on a high note as Dr. Matazar talks about survivorship issues, and then we'll finish up. So thank you all. So some of the demographics that we're well aware of is the fact that our patient population is getting older as a result of the baby boomers, and that malignancy disproportionately strikes older individuals. And this is not just a US phenomenon, it's a global phenomenon, and really some of the European countries like Italy and France and Japan have really been ahead of us in terms of addressing this in terms of their therapeutic approaches. Some startling facts, though: 70% of all cancer deaths are going to be in the patients over the age of 65, and for the malignancies that we deal with, their median age is already in the mid-60s. And that's been a increasing incidence across the older demographics, such that septuagenarians and octogenarians are really frequent in our waiting rooms. And we know that there's problems particularly prevalent in the elderly, and they entail comorbidity that limits our curative options, diminished organ reserve, increasing infectious complications, polypharmacy, issues of ageism, and a lower representation on clinical trials. And although this is older, it remains true across the field of oncology that when we look at the percent of patients with cancer who are older, there's a large percentage, but the number who actually are on representative clinical trials remains low. I would actually advocate that the lymphoma community has done a good job of having specific studies for older individuals, but we still start to fall off in individuals above 70, which is a very prevalent population. So the representation in patients in their 70s and 80s is still quite low in terms of clinical trials. And we have identified some of the barriers, but not all of those, to participation in clinical trials. There's certainly a toxicity aversion in older individuals where there's a focus on quality of life and not necessarily on quantity. And issues such as grade 2 nausea are quite magnified in an older individual who's reliant on family members for their care compared to someone who's younger. Ageism has been at play, and I'll show you some of that data. Physician recommendation is actually, and nurse recommendation, is one of the strongest factors in terms of participating on a clinical trial, and that's where we can intervene to impart, and logistics. And like many centers, we've been engaged in developing a regional care network, and many of us are now at those sites to bring the access to novel therapies closer to patients, acknowledging that distance is an issue. And then you heard a little bit from Jonathan about the intentional and unintentional eligibility barriers that we put into clinical trials. And we'll often throw in a creatinine clearance requirement that it restricts people just based on their age when you actually use a Cockcroft-Gault. So I think when we're sensitive to this, we can identify that we're precluding patients from participating on trials indirectly, and there's a systematic review that really looked at randomized controlled trials and found that about half of patients were indirectly excluding the older individuals as a consequence of eligibility criteria, with a whole lot of caveats. So we did look at phase 1 studies in lymphoma patients at Memorial. These patients were already selected to participate on a clinical trial, so they've gone through that filter. But one of the questions that we wanted to ask, and we have a fellow who's interested, an attending who's from Israel who's interested in looking at this, we asked the question, do older individuals actually have more toxicity on early stage studies? And this was predominantly in an era where there was more cytotoxic therapy, less targeted. And when we asked whether or not serious adverse events or DLTs were increased in those over the age of 60 or over the age of 70, there really was not a significant difference, despite the fact that there was more comorbidity in our older patients. So I think what we can say is when we choose clinical trials for older individuals, we're not demonstrating a negative impact in terms of greater toxicity, whether or not we're filtering really well in terms of who we recommend, or we should be more able to broadly apply clinical trials, I think is something we still have to work out. Ultimately, what we'd like to be able to do using large cell lymphoma as a paradigm is to integrate age, function, and comorbidity with both disease and host factors, recognizing that disease biology does modify as we age, and that's true in a number of different histologies. Large cell lymphoma we'll focus on today, but certainly in Hodgkin's as well. host factors we'll talk about, and then can we come up with risk-adapted strategies that maximize outcomes and quality of life. I always find it's helpful to know who we're treating in the first place, and somewhat startling to me when we looked at about 9,000 patients with large cell lymphoma over the age of 66, so this was SEER databases enrolled in Medicare A and B. We just asked the question of who's getting treated in the United States with large cell lymphoma, and in a concert diagram, we started out with 46,000 patients, got down to 9,000, and a quarter of those patients never received any therapy and were recommended hospice or palliative care in the United States. A third of those were getting a treatment, but that really included our monotherapy, our chemo, or chemotherapy only. And as you might expect, the incidence of non-treatment increased with age, approaching upwards of 40% of patients being recommended more palliative care if they were in their 80s. And that may be appropriate based on their comorbidity and wishes, but I think we have some suggestions that ageism was at play in some of this decision making. And this is very true as well if you look in the Netherlands, where they have a good population-based data, where upwards of 75% of patients in the octogenarian range are not really being offered any therapy. So if you look at both in the US and again in Sweden, where they have population-based registry data, in an era before rituximab, the outcome for patients over the age of 80 in terms of long-term survival was quite low. In a post-rituximab era, improvement increased, and it increased at a rate that was much greater than the benefit from rituximab. So I think what we were seeing in part, and that was supported in the data, was that there was a greater willingness to consider a curative intent as you had increased therapy that was successful. And this was looking at patients specifically with curative intent delivered therapy in a post-rituximab era. In their data set, it was over 70% of patients were cured. So why are outcomes worse in our older patients? We know that age figures prominently into all of our prognostic models and likely is capturing both disease biology as well as multidimensional comorbidity with the aging process. And it remains predictive in a chemoimmunotherapy era where we now can dichotomize outcomes probably closer with an age around 70, 72 when you look for that inflection point. No longer is 60 perhaps as relevant, and that really is an anachronism of an era where transplant was limited to patients under the age of 60 in part. From the German molecular characterization project, actually we see that with increasing age, the molecular complexity, looking across multiple different molecular markers, increases. And we know that in large cell lymphoma, we see an increase in ABC phenotype with increasing age. So that's shown in red there. And that has a association, as we've heard throughout the day, with worse outcomes. And double hit biology is also increasingly seen in older individuals. Median age is in the late 60s. There's a higher CNS relapse rate. And we see this both with an increase with FISH translocations as well as in double hit. Poor outcomes with R-CHOP, and the question is whether or not other therapies like dose-adjusted EPOCH make a difference. Colette Owens, who's in the audience, has looked at our experience with dose-adjusted EPOCH in older individuals, and we demonstrated that it can be effective and curative in patients in their 70s and 80s, although toxicity is certainly present. We have many predictors of toxicity. Our ability to codify this and to really speak with patients before we give them chemotherapy today is still a work in progress. And we know that reliance on things like performance status has been insufficient. So that's really led to a desire to be able to quantitate comorbidity, which we know is independent of the IPI and can result in lower survival, and to have ways of measuring frailty, which is a separate physiologic function from comorbidity, and is really dependent on having a number of defined clinical features like unintentional weight loss, poor endurance, slow gait, and low physical activity. Nutritional status also plays in with this, and our colleagues from France have demonstrated that you can predict for early death with features as simple as a low albumin and a mini nutrition assistant. In terms of being able to codify sarcopenia and frailty, there may be ways to use CT imaging to look at muscle mass in the psoas muscles. And I think what is instructive as well in the Venn diagram at the bottom is that frailty is not restricted to those who are thin and of small body frame, but actually you can see that across normal BMI, overweight BMIs, and certainly prevalent in those with lower BMIs. And sarcopenia, as defined here, at least radiographically, was independent of IPI and had an impact on outcome. Geriatric assessment is a process that is somewhat time-consuming. It looks across multiple domains, but does pick up additional toxicity potential in our older individuals. And it's recommended by all of our guidelines, really, to be integrated into the thought process for older individuals. And yet, in clinic, we still lack those tools to do this in an easy way. There are a number of screening tests that can limit the number of patients you refer to geriatric assessment. And we've tried to come up with an approach that can be electronically administered simply and broadly, with work from our 65 group with Armin Shirokin actually doing excellent work in solid tumor right now, looking at an electronic version of this, and Arthi Huria, who was initially here and now at City of Hope, developing a self-administered geriatric assessment. And I like to point out that something as simple as gait speed predicts for mortality in a very significant way, and that's integrated into part of these assessments. So at the age of 75, your 10-year mortality, just based on your ability to walk at meters per second, can range anywhere from 19 to 87% in men and 35 to 91% in women. So watching that patient walk down the hall can give you an awful lot of information, and we've built that into a prospective study to see if it's predictive of outcome. So the CARG geriatric assessment takes about 17 minutes. It can now be given as an electronic version, and it's designed to predict grade 3 and 4 and 5 toxicity with therapy before it's administered. Martine Eksterman from the Moffitt group did a similar type analysis with a crash score. And what you see here is the increasing rate of grade 3-4 toxicity based on a total risk score with this geriatric assessment, as opposed to the predictive value of KPS, which was quite poor. And it comprised of about 11 factors that predicted for outcome, but it was predominantly a solid tumor experience. When looked at by Dr. Tucci in Italy and using CGA versus physician judgment in elderly large cell lymphoma patients, I like this because it's instructive. For physicians, we opted, independent of the CGA, to determine whether curative or palliative intent should be given. And we had erred on the side of curative intent. So about 2/3 of patients, we recommended curative therapy, and 22 of those patients palliative therapy. Nevertheless, the geriatric assessment broke down about exactly 50-50 in terms of fit and frail. So when the geriatric assessment and the physicians were concurrent, the outcomes were excellent. Progression-free survival 73%, overall survival 78%, with high response rates. But when we were at odds with the geriatric assessment, the overall survival and outcomes were very similar to when we actually had identified the patient as being appropriate for just palliative therapy at the onset. And somewhere between 1/3 and maybe 20% of our patients fall into this category where our gestalt, our clinical judgment, is off, and we need tools that can help us. And we can see in part that geriatric deficiencies are identified even in patients with good performance status. When we say KPS of 80%, if we look across 41% of those patients when you do geriatric assessment are limited in their physical function. They have geriatric impairments across multiple domains. Despite the good performance status, 70% of patients have at least one deficit across those domains, and there is social isolation at play as well. And that was work from Hi Muss's group. Prospectively, Colette Owens, again, has been working with myself to try to identify whether or not there's ways to impact some of these negative geriatric themes, as well as to understand whether or not geriatric assessment can predict toxicity in a lymphoma-specific population. So we are nearing completion of the study. It's slow getting there. About 200 patients are planned in the overall experience. And we currently have, I think, about 125 patients with geriatric assessment being performed pre-treatment and then sequentially over therapy. Built into the study was a disease-modifying intervention to try to improve outcomes by using a pre-phase. Our colleagues in Germany had used a pre-phase to try to identify ways to decrease early progression or toxicity. They used a vincristine and prednisone week, And in the Recover 60 experience, demonstrated that when they instituted pre-phase, they were able to result in a 50% reduction in mortality, which tended to occur in cycle 1 and cycle 2, presumably by improving the physiologic reserves of the patient before chemotherapy. Not believing that vincristine was an ideal agent, we had opted to use prednisone and rituximab as a pre-phase regimen in our own study, and patients received a week of steroids along with a single dose of rituximab, and then went on to therapy that was R-CHOP-like. And this data that we put together, the median age was 75. It's a small experience. This was more of a pilot experience with 33 patients. They tended to have the all-aggressive histology, advanced stage 60%, and high intermediate or high-risk disease in about 60% of patients. A fairly even split between GC and ABC, slightly lower despite the older age for ABC biology. And about 50% of patients had intermediate or high-risk comorbidity. And with the pre-phase, we are able, at a very early time point, to demonstrate good outcomes. So patients were generally able to complete therapy. And we looked at cytokines as well as some of the geriatric assessments. And without going into the details, the pre-phase seemed to ameliorate disease-related effects. It improved the LDH. We did not have tumor lysis despite patients who were at risk. And we saw a decrease, at least within the confidence intervals of 33 patients, in treatment-related mortality, which in our past had been at the 10 to 13% range in this median age group. It did not measurably improve host factors such as KPS or timed up and go at a 1-week time point, and inflammatory cytokines did not modulate with the pre-phase, but baseline inflammatory cytokines were associated with the higher risks of poor outcome. So I do think that there's a component of inflammatory cytokines that are at play prior to treatment. From an algorithmic framework for decision-making for older individuals in clinic, we'll often use life tables and e-prognosis to really help the patient to understand what their risk of dying from the lymphoma is in conjunction with their life expectancy. And it's always surprising when you have an 80-year-old and you look at their comorbidity and calculate out their life expectancy in the absence of lymphoma, and that life expectancy is 5 to 7 years. And I find it's an instructive exercise with our fellows and med students. We try to integrate the geriatric assessment and predictors of early treatment-related mortality. And if patients have a life expectancy under 2 years and are at higher risk for toxicity, I think we're really thinking about palliative intent. But for the majority of patients, life expectancy usually is greater than 2 years, and we have to come up with strategies where curative intent makes sense, acknowledging that treatment's about 5 to 6 months, and then there's a recovery period. And we do know from work done by Jimmy Holland, who's really focused on the care of older individuals with cancer at Memorial for decades, that the goals of care are to avoid dependency, avoid cognitive decline, and loss of quality of life, and that often it trumps quantity. So those discussions we have up front. We'll use a pre-phase and then adjust therapy to try to minimize toxicity but still maintain a curative outcome. And I think in the pre-rituximab era, reduced dose intensity was certainly associated with inferior outcomes that made us loath to give lesser treatments. But in the current chemoimmunotherapy, if you look across the board at approaches such as our mini-CHOP, which used a 50% relative dose intensity, median age was 83, so these were patients all over the age of 80 from our French colleagues. The progression-free survival at 2 years is at about 50%, overall survival 60%, and treatment-related mortality in the single digits. And in a similar vein, a non-anthracycline-based approach by our UK colleagues also has about a 60% 2-year overall survival with the GCVP program. I'm not enamored with the activity of bendamustine, but there's certainly efforts looking at that as well in older individuals. So I want to thank the geriatric program here. It really is a multidisciplinary approach, and my colleagues for helping us to try to quantitate ways to measure toxicity in advance with the forward thought that that will inform risk-adapted therapy in the future. And with that, let me conclude, and I think I'm happy to take any questions.